Hello and welcome back to the Advancing Healthcare Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, man, we're super excited to have you here. You know why? Because we've just got some incredible conversations that have been going on with some very passionate leaders that are focused on improving access, focused on leadership, innovation adoption, and a number of other really cool topics. And if it's your first time tuning in, why don't you just hit the subscribe button now so any of these other interviews come right to your inbox and you can check us out. So as part of our commitment, our objective is to really talk with folks that are really innovating, that are truly doing things on the front lines, and that are improving things and giving us the opportunity to really shine the light on them and sharing some of the best practices and even a bunch of the learnings. Because after all, if you're not innovating, then you have to be learning with that. So I'm incredibly excited to introduce our next guest here, Dr. Douglas Slakey. He's acknowledged globally as an excellent transplant surgeon and authored more than 150 peer-reviewed articles. He sits on the editorial boards of various major medical journals and has an abundance of reference abstracts under his belt. Not to mention, with over 30 years of experience, he's really climbed to the top of a number of different leadership roles in various healthcare settings, and he's passionate about really making changes for the better. And he never stops hunting for ways to improve processes and lead teams. And Dr. Slakey firmly believes that you have to put the patient first. And he just loves finding ways to improve and make systems better. And most recently, he held the post of Chief of Surgical Services at Advocate Aurora Health. And during his time, he provided direction and advised on future plans for surgical services across 27 hospitals. So quite a big feat. And he was using his skills really and influence as a well-respected surgeon, introducing new ways of doing things, which ultimately led to better healthcare practices. And currently, Dr. Slakey is a published author. We'll talk about his book today. And he's the president of Process Health, a consulting company that improves how healthcare facilities operate, focusing on ways managing complex systems. So Dr. Slakey personifies compassionate leadership and having an innovative mindset that really modern healthcare landscapes require. So Dr. Slakey, it's amazing to have you on the show. Welcome.
Well, thank you so much for that kind introduction, Michael. It's really a pleasure to be here. And, I'm particularly excited just to explore some of the ways that we can empower people to make healthcare better. I think one of the things that really excites me, especially after publishing the book last fall, is that it's been a way to start conversations and to get people talking and engaged. And I think there's nothing more important than that. Really, the idea that you can have people generate their own enthusiasm and passion and realize that within each of our small spheres of influence, we can actually be a positive force.
So I love it how you just mentioned that, because that creates an on-ramp to a lot of different talking points. Let's kind of take a step back, because you really were at the heart of a team. When you think about innovating, you think about small teams. And being a surgeon, can you talk maybe about some of the lessons you've learned working in small teams, and how can that translate across an organization? I mean, when you mentioned about the seat that you sat in, treating patients, but then also looking at things at a large macro view across 27 hospitals, how do you get that same tight-knit team effort to span across multiple sites?
Yeah. So, I tell you, it's really a journey. Let me give you just sort of an example of how my thoughts evolved on this. So,
Yeah.
as a transplant surgeon, I think fundamentally it's a little bit unique because in transplant, we've solid organ transplants. I did liver, kidney, pancreas, and small bowel. And we really focused on this idea that we had to have the surgeons, the medical physicians, the pharmacists, the nurses, social workers, and put these all together. And rightfully so, we thought that we could provide more comprehensive care to patients and understand the patients better. And that's true. And as you think through that, though, you realize that the interface between a provider group, even a team like that, and the patient is really just one portion of the patient's healthcare journey. And that from the patient's perspective, those interfaces, even if it's a fairly large group, are very episodic. And I
Mm,
think one of the fallacies that we have on the provider side is we think those episodic visits are really painting our entire picture of the patient. One of the things that really changed my thinking about this was when I was at Tulane in New Orleans. Many of my patients became almost family friends. They had my cell phone number. Some still do, and they call me up, 10 or 15 years after I transplanted them. And I'll never forget, Michael. We went um, to this area called Avery Island, which is where Tabasco's made for a weekend. My wife and we were driving back on this very rural area. And one of our patients who'd had a liver transplant always came to clinic very put together. We thought we really knew her, and she kept coming back with infections, and we couldn't figure it out. Why did she keep coming back with infections? So anyway, we were on this weekend trip to Avery Island. We were driving back, and I looked at my wife and I said, well, let's stop off and see this patient. The little town where she lived was there. So we drove around and we found out where she lived. She didn't happen to be home. But what we saw was her house was what many of us would consider a garden shed in the backyard.
mm,
Um, she lived in a very rural, very impoverished area. And it struck me as we drove away that while we have this big team, social workers, all sorts of people, we really didn't know this patient. And a light bulb went off in my head. And I said, well, now I know why she's getting these infections, just because
right.
of the environment in which she lived. And I realized that what we really had to do if we were going to be patient centric was to change our mindset and put ourselves in the position of the patient and what was really the entirety of their healthcare journey, and change the way we looked at resources, knowledge, and education, and align them better with the patient need rather than what we saw as the primary things within our clinic or the four walls of the operating room. So that was really an enlightening time for me. And it really got me thinking that we need to change our perspective and change the way that we create our policies and our processes so that they favored the patient rather than the convenience of the provider.
Mm. Well, how did the rest of the team react to that new mindset, to that new vision
Yeah,
that
I
you all
think it
implemented?
was honestly it was eye-opening, and we realized that we had in some ways sort of let the patient down, because as she came back with these recurrent infections, we started to blame her. She must be
Mm,
doing something wrong. She must not be taking the antibiotics, must not be compliant the way she should be. And we didn't realize that it was more than that. It was really some environmental limitations that we could help with, and we could give education and instruction um, to mitigate some of those challenges. So I think it was really eye-opening, and we realized we had to ask different questions. We had to be more consistent in the way we followed up with the patients, and we needed to look at other sources of information, whether that was from relatives or friends or things, to put together a picture which was more representative. Sometimes we try we create these very linear pathways, which are useful, but if we over standardize, if we're over reductionist, we try to reduce every patient to some sort of very uniform construct. And
Right.
that just doesn't adequately represent human beings.
Mm. So now that you've sort of taken this sort of humanistic approach, um, when you look at surgeons, I've worked with surgeons throughout my career. You know, you get one patient, you get 10 surgeons, you get 10 different approaches. And it's sort of like herding cats. What did you find
Yeah.
best in terms of approaching your colleagues and peers about evaluating this type of approach and not just looking at things inside of from a surgical
Yeah.
perspective, rather more of a whole person type of care?
Well, so it's really it's amazing to me how you can approach this if you promise the provider, the surgeons, their teams, that what you're doing is helping them to optimize their performance. And that changes the dialogue, right? Rather than telling people, here's what you're doing wrong, here's what you need to do to fix it. The question then becomes, what, as a leader, what can I provide? And how can we give you resources so that you can do your very best job and be most reliable and most consistent and understand risk? And so a good example is we looked at postoperative complications like postoperative respiratory failure. And there was a couple of really interesting things as we looked at the processes around this. This is really illustrative. First of all, as individuals, yeah, I love the way you mentioned the 10 surgeons and you get 10 answers. As individuals, there was no real understanding of the scale of postoperative respiratory failure. Each surgeon may have seen none or one during a
Mm,
year. But
mm,
in aggregate, as we looked at this problem, we had maybe 20% above the expected rate of postoperative respiratory failure. So the first thing was to really understand that as individuals, people didn't have this broader perspective. And so we needed to educate people. And that's so important, ongoing education and training, so that people really understand, okay, well, what's the problem we're trying to deal with? Then what we realized is that some of the postoperative respiratory failure that we were seeing could have
right.
been could have been reduced by aligning resources, certain medications with certain
Mhm,
patients, but there was no way to identify these patients. So we worked with a very broad
mm.
constituency and we actually flagged patients to get the right treatment early on. And just that process of engagement, making things easier to optimize human performance made a huge difference.
So it sounds
And
like what you really are focused on is like, hey, what is the common theme problem that we
yeah,
all care about? And when you kind of align around that, what does optimal human performance look like individually and collectively? You
yeah.
know, when you're
So,
able to see it, what does that look like?
well, so I think well, first of all, we have to agree on the outcome metric, right? That's
Okay.
so important. Often we look at intra-process measures, like how fast do we turn over an operating room, or what's the wait time in the emergency room, something like that. And while those are important, they're not really necessarily telling us how the patient is doing. So that's the first thing is we have to agree upon what's the ultimate outcome measure, and then how can key performance indicators be aligned with supporting that ultimate outcome measure. And that
Yeah, I mean,
breaks
so,
down,
so
yeah,
just want to comment on that because what you're saying is those other metrics, although important, they're important to the facility, and because you're sort of reconstructing everything to be centered around the patient, um, that's really your emphasis. I understand.
yeah.
Okay,
Yeah,
keep going.
well, and when you think about the frontline healthcare provider, that's their goal. Their goal is to get the patient the patient journey and the patient care as optimal as possible.
Yeah.
Much of the frustration comes in when the key performance indicators are facility-based or policy-based, and they don't seem to be tied directly to the performance of the provider. So that's one of the first things. The second thing is to have the willingness to decentralize control and empower people to use
Mm,
their skill and judgment to align resources with patient need, ideally individualized patient
right.
need, and then also to reward incentivation within that environment. There's a
Mm,
really interesting concept called adhocracy that I learned about as I worked on complex system theory. And yeah, it's in many ways it's the opposite of bureaucracy. We think that bureaucracy, centralized control, will really help us reduce variability.
mm,
And to a certain extent, that might be true. We have to have standards, but that's different from over standardization. And adhocracy is really interesting. The term was coined around the time that President Kennedy made the challenge to put a man on the moon. And there were two potential approaches, right? You could bring experts together, and we have
mhm,
to remember it was a very small timeline, a tight timeline. So you could bring up experts together and you could put somebody in charge and say, this is the way we're going to do it. But that was felt to stifle innovation. So adhocracy is where you have a goal. The goal was to put man on the moon. So in healthcare, our goal is to optimize the patient journey and patient health. And then what you're doing is you're bringing experts together and you're allowing them to have this generative environment where they can
mm,
use the tools that we described, and also situational awareness and individualization, and they can attend to those patient needs, which is really powerful when you think about it. But on the other hand, for some who really believe in very tightly controlled policies, it can be somewhat intimidating.
right. Well, in a world that a lot of facilities play in is a fee for service world, and there's a lot of talk around with value-based care. Where do you see the transition of this falling into? Does it fall somewhere in between? Because at the same token, I'm thinking, all right, if I'm an operator and administrator of a health system, no money, no mission, but
Right.
the caregiver side of me is thinking, well, if we treat people well, that does make a lot of business sense. Where do you fall? Where does that fall?
Yeah, so yeah, that's a good question. Obviously, with some of the fee for service models, there can be perverse incentives
Right,
put into the environment. But where I really think it falls is when we look at models, financial models of healthcare delivery, where more of the consumer power is placed in the hands of the patient.
right,
I think that's going to be a dramatic shift. We can see that in other industries. You know, the travel industry is a great example. As consumer power shifted to the traveler, the ability to book an airline ticket, the ability
right.
to book a hotel or anything, anywhere in the world, right? And with a high degree of reliability, be assured that you're going to get the experience you want. I think that's going to be really the big shift. And then the consumer will have their perspective of what value is to them. And that
Mm,
gets back full circle to this idea that we don't always really understand our patients, and we still have a high degree of paternalistic view that people can't understand. And while that can be true, some of it's very technical. it's it's not that different from other industries, really. Like as a passenger in an airplane, we're not flying the airplane, but we have a high belief, an
Mm,
incredible belief in the safety and the reliability of that. And furthermore, when you think about what you have to do if you're really focused on the consumer experience, just think about airline travel. And you can go anywhere in the world, really, and
mhm.
go through any airport, even if you don't know the language, you don't know the culture, and you can get into the airport, you can check in, you can get through security to the gate almost 100% of the time with a high degree of reliability. Try to go to two hospitals, even in the same city, and get from the front door to radiology. And that's because we haven't designed the environment from consistently from the patient's perspective. We've really designed it from the facility's perspective. So I think I really think that's going to be the transformational point when we give the consumer, the healthcare consumer more choice and more power in exercising that choice.
Mm. So what has your focus, your intention, for I guess the next 6 months? Where are you focused?
Yeah, so I'm really excited about putting together packages of educational content to really move this message forward and get people talking and thinking about how can we really make a difference and how and give people some strategies to actually create empowered teams within their own environment. And I can't emphasize enough, Michael, how important it is when we look at these teams. We have to think outside of
Right.
our own box. I can give you one really quick example.
Yes,
Uh,
please.
being very inclusive in creating these teams. So we were looking at, like everybody does, we were looking at ICU infections, right? I mean, that's everybody looks at that constantly for all the right reasons. And usually you have the physicians and you have the nurses. Well, we created a team that we looked at the process of getting patients through the ICU, and we included everyone on the team. And one thing that we discovered that none of us as physicians had thought about, we had environmental services, and the environmental services came and they were talking about cleaning the beds. And they said, well, because of staff shortages, we can't actually lift the mattresses up because we only have one person going in the room at a time. And these mattresses weigh nearly 60 pounds or 70 pounds or something. And I'll tell you what, we took a little field trip up to the ICU and we lifted the mattress off a couple of the beds. And
I had no
I
idea mattress weighed that much.
oh yeah, because they're these big, heavy foam mattresses now. And that's an example of how if we didn't have that diversity in the team and we didn't allow people to speak up, it gets back to the whole idea of stop the line and speaking up. We would never have realized that the simple act of cleaning under the mattress and in the springs and things was not it wasn't just that it wasn't being done. People wanted to do it, but they physically didn't have the capacity to do what they wanted to do. And so I think that's where and the teams we created, they discovered this without on their own and came up with solutions generatively.
What did they end up doing?
Well, there were a couple of things. So one is they got a colleague to help with the mattress. But then the other is we started exploring new solutions for mattress covers, which
Mm,
exist. And that got me into learning the whole thing about micro tears in the covers with the cleaning solutions, things that I had no idea about. And we were constantly focused on the same things that we've always been focused on, like everyone has to wash their hands and everyone has to change their gloves. Very important, but that in and of itself would not solve the
Mm.
entirety of the problem. And so we looked at novel approaches, ways to partner people. Um, that led to processes which were much better at notifying environmental services when, to give them more time to allow them to have two people instead of just one person doing the cleaning. So these different strategies came, and we didn't push them. I think the key is we didn't push these things from the top down. They
Right.
were truly generative, and we had to open our minds and ideas to alternative solutions to problems that honestly
Right.
we didn't even know existed.
It sounds like it's more of a pull than it is a push. And there's always going to be more strategy, right? I mean, for the leaders that when they go to school, they learn about strategy. What I'm convinced of when it comes to innovating, and the way that I define innovation is, being able to add value to many and incrementally getting better over long stretches of time, is that it's about execution. And like when you go to school, what do you learn? You learn strategy, or you learn how to execute. Well, you
Yep.
learn strategy, you spend more time there. What have you found in your experience is that allows a team to execute, based on what you mentioned, them organically coming up with something? What is it that gets them to want to execute, not just once, but over and over and over and over again?
Yeah, I think, well, first of all, I think that amongst any group of professionals, there's a personal um, reward, which is very important, um, and that has to be acknowledged, and it has to be acknowledged in a way which is, again, not really episodic, but almost continuous. That feedback where they see the changes they're making make a difference. And so that's that understanding the feedback loops. I love the plan, do, care, act cycle of continuous quality improvement. And
Mhm.
and the key there, Michael, is the word continuous. Often we look at problems as, again, being very linear, and we're just going to fix something. Fixing something is different in perspective and action from continuously improving. And so I
Right.
think as a leader, the 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 core principle is to always be inquiring, what can we do better? How can we continually make things better? And to seek alternative perspectives and to be open to it. We have to put things like confirmational bias, where we're looking for answers that reinforce our own pre-existing ideas. We have to
Mm.
put those concepts aside. Um, I'll give you another, just a quick example of one thing we did with teams, which I thought was super interesting. Was
Yes.
we were looking at some specific solutions about optimizing patients before surgery. And traditionally, we had had the orthopedic surgeons work on the orthopedic patients and the general surgeons and the general and all. So,
Mhm.
what we actually did was we took orthopedic surgeons and put them on the general surgery team. We took cardiac surgeons and put them, for example, on the OBGYN team.
Mhm.
And we realized that here you could bring people who were truly expert, very experienced, and when they started to look at other services, they pointed out things
Mm.
that those within their own sphere of influence weren't seeing. They weren't seeing because they had these cognitive biases that they were already doing everything right, and that maybe the system was conspiring against them and they
Yeah.
couldn't see
Yeah.
change. But when you brought these other voices together, you actually started to see um, really a lot of interesting, generative, thoughtful, innovative approaches. And then you could share those best practices across these different silos, across these different areas. And of course, you realize there are much more things in common than not in common. Once we step back and look. So I think that's a great example. And let me tell you, when we first started this approach, as one might
Right.
imagine, there was a very high degree of skepticism. Like, what does an orthopedic surgeon know about, my gallbladder surgery or
Mhm.
something like
Right.
that? But when you think about it, just that technical component is just one. Again, going back to the patient's perspective, that technical aspect is one small piece of what the patient sees. And
Yes.
so when we look at the broader view of outcome and what are we putting in as the hierarchy of our outcomes, then it really changes the dynamic. And people become, the other thing is, in that sort of strategy, people become supportive as opposed to competitive. And
Right.
then they start to look and they see, okay, well, where can we share resources? Where can we share best practices? Where can we share commonality in the way that we move our patients through the system? And of course, if you think about that, one of the ideas of reducing variability is to find common ground, right? To
Right.
have uh, established normative behavior. And so that process that we embarked upon was really powerful. And to get back to part of your original question, is because people saw the value that they were providing others, as well as realizing the value that they could bring to their own group at the same time.
Right.
It wound up a bit, literally developing a life of its own. And then it requires very little oversight.
Mm.
You can give people a direction. Here's a project to work on, and let them go for 2, 3, 4 months, um, with a few touch points in between, just
Yeah.
to make sure that there's some progress. And you don't have to, as a leader, you really don't have to be overly controlling and burdened. Sometimes we have too many meetings, and we
Yeah.
can get away from that.
Yeah. I mean, it's a beautiful example of what you mentioned. You're directing, not dictating, and just
Yes.
sort of doing it at an arm's length. So as you start to put together some of this creative educational content, what other ways are you attempting to kind of leverage it, use it? How do you envision it going from there?
Yeah, so I've exploring a couple of different avenues. Earlier today, for example, I was talking to a professor at a School of Public Health in North Carolina, and we're working on a special interest course. Um, I think the other, and so I think actually schools of public health, like healthcare administration, master's type courses, are great because there's a lot of fertile ground there. Um, I think other venues like the Institute for Healthcare Improvement and some professional societies really offer um, some venues where this kind of content, I think, will really resonate. And
Mm.
then the other thing is, I do believe that one of the things that I'm really excited about is I've been increasingly asked to do some advising for innovative tech companies. And this is really fascinating because there are these super smart people that realize, and many have come from outside healthcare industry, right? And they realize that there's this amazing opportunity to improve and a need. Like if you look at a recent Gallup poll, most people in the United States give our health system a C minus D plus rating. So we're really not doing as well as we think. And so they see this need. And what I find fascinating is to work with people and open their eyes to see, well, how can we take these, especially tech enabled and tech inspired solutions, and translate those in a way that acknowledges the true need is to do two things: improve human performance on the front lines of healthcare, provide people those resources and tools, and then also to acknowledge and understand the individual patient reality. So the
Mm,
context of health, the social determinants of health, and then their own medical history, genetics, and physiology. How do we blend that all together to really allow us, like going back to our early conversation, the woman with the liver transplant who lived in that very rural, impoverished area? How do we change our delivery of healthcare to be able to appreciate the need to individualize and the need to address those changes? And then, really, well, I'm the eternal optimist, so I believe that the money will naturally follow from two perspectives. One is that we can substantially decrease waste if we align the resources where they're needed and are able to tailor them. We can reduce the waste of trying to do everything for everybody, which we don't need to, right? So we can tailor that. And the other thing is we can, by individualizing care, we can more accurately recognize need. And,
mm,
for some patients, maybe we can use remote patient monitoring and we don't need to see them as frequently. And we can interpret how their vital signs and behavior are influencing health. And then we know how hard it is to get some physician appointments, right?
yeah.
So we can actually improve access by prioritizing
Hmm.
need with availability. And we don't do a very good job of that right now,
Right.
right? Like I tell you, when we moved from Chicago to California a year ago, I take one blood pressure medicine, a fairly low dose, but I take it, and
Okay.
it's been the same for 15 years. So I call up the primary care here and I said, "Oh, I'm new. You're my new primary care. We can see you in 6 months, Dr. Slakey." "Okay, well, yeah, but I need a renewal of this blood
Mm.
pressure medicine." "Oh, well, we can't do that without seeing you." And I said, "Well, look, I'm a doctor and I know what it is. I've been taking it for 15 years. Well, you'll have to go to urgent care and be seen in the emergency room or in urgent care, and then they can get you your renewal prescription." Well, what a waste is that, right? So this
That's
is
right.
where technology, I think, and getting back to that idea of empowering the consumer, what a difference that'll make, and what an avoidance of excess cost and waste. And my example is just one simple example, right? Just think how many thousands of times that's repeated across our country every single day. And
Yeah.
if we,
The magnitude is just unbelievably high.
yeah, it's staggering. And that has so many consequences, both at the individual, population, and public health level. So I'm really excited, and I think this idea of helping to implement, and I think that's really important. We have some of these solutions which are brilliant, but it's the implementation and actually getting them into the hands of the frontline provider in a way which is allowing them to do their job more effectively and more efficiently. And also to acknowledge that we have to have that continuous improvement. The solutions are not just one stop, right?
Right.
It's an evolution. And so that's what I'm really excited about is being part of the process to help people, almost like coaching, to help people use these technologies, these process improvement strategies to actually be much more engaged, satisfied, and effective.
Brilliant. So since you mentioned process, maybe we, as we're winding down our conversation here, you share a little bit about your book and
Yeah.
ways in which, folks can continue to follow your work and some of the projects that you've been on.
Oh, well, thanks. So, well, opportunities like this, the podcast with you is a great way to follow some of this. So, my book, The Process Manifesto, Improving Healthcare in a Complex World, I really wrote it for two main reasons. One is to stimulate people to have these conversations, and the second is to provide people a roadmap that they can use to get these team initiatives started and
Yes.
moving forward to implement them. And I really, as I thought about the book, it was really fascinating. I had just amazing writing coach and editor, and they asked me early on, well, what's your target audience? And initially I thought, okay, healthcare administrators. And I thought, well, no, frontline people too. And then I sent excerpts of my book to lay people, um, a huge variety. And I got this amazing feedback that it was actually resonating because I put in examples and stories from the real world about
Right.
the complexity of the patient's experience and the frustration that healthcare providers and the misalignment of incentives. And then I came to this amazing realization, which sounds simple, but actually I thought a lot about it, is that at some point in our lives, each one of us is a caregiver and each one of
Right.
us is a patient. So it's not us versus them. It's a
Mm,
really a continuum, and we all have to be part of the
right.
solution. Um, and that was an eye opener for me, honestly, thinking that way, because
Hmm.
as a transplant surgeon, as a healthcare administrator, you tend to really focus on your side of the equation. But then you
Right.
realize, no, we're all part of the whole process, right? We all have a stake in the game from both perspectives. And
Absolutely.
so, yeah, so that I think that's just I'm really excited about that perspective and realizing that if we can even encourage a small number of people through reading the book to and use, you have to come up with your 10
Mhm.
or so core principles, right? But to use these principles to say, wow, there are really actually very simple ways that I, as an individual or a member of a small group, can
Right.
start to look at changing and revising things. And then you think about, by extension, that could even um, influence policies at the local
Yes.
level, the state level, or the government level, so that we really start to think about, well, how do these policies that we enact affect that ability of the healthcare professional to do their job? And
That's right.
so I think that's super important. And then the last thing that I put in, my 10th principle, was to be compassionate, because I really do, as I finished the book, I added that at the very end, actually, as I finished the book and reread what I had written, I realized that much of what I was advocating for was that people actually understand the perspectives of others. And
Mm,
it's more than empathy, right? Empathy is, feeling other people's suffering, but compassion is this action, actually doing something about it and making um, other people's healthcare journey, whether you're the provider or the recipient, smoother, easier, more reliable, more predictable. And so I included that purposefully because I thought that it would stimulate people to really think about, at the end of the day, why are we doing what we're doing?
Right. Right.
Yeah.
I love it how you talk about compassion as an action associated to it. And we didn't talk about this beforehand, so this wasn't pre-scripted, but if there is one action that you would want someone who's listening to this conversation right now to take, what would that one action be?
I think the one action would be to be more transparent and honest about um, both your motivation and the existing frustrations. I think that particularly on the healthcare provider side, when we look at burnout, and even unfortunately, we're seeing some increase in addiction and even suicide
Yes.
within healthcare providers. To me, that's um, really a cry for help and a realization that we're not in this on our own, that we really need to share. And I think that's true for the patient. You know, as you go through your healthcare journey, there's a tendency to be um, to internalize your issues, to not
Right.
share, to not being open. We can go back to the liver transplant patient story, but she didn't share that. She wanted to tell the physician and provider team what she thought they wanted, what we wanted to hear, right? So I think if there was one thing, I think I would say to everybody to actually be more honest about what are the frustrations you're feeling and to make sure that you articulate those um, uh, with either your colleagues, your provider, because that's the first step to identifying what are those issues in the process which are not working.
Yes. Yes. Well, I think that man, what a really fun conversation. And there's so much more that we can cover. So, for those that have been tuning in and listening, if you found this conversation particularly helpful for you, um, would, would you mind sharing it on your social media, commenting it, liking it, and honestly, even just for us for the feedback? What stood out to you? What are you going to implement? So, if you want to list that in the comments, that'd be super helpful. And Dr. Slakey, it's been really nice chatting with you and just getting your perspective. And I can just say that your level of compassion really came through today and just being rigorously honest. So thank you for the work that you're doing, the work that you have done, that you are doing, and that you will continue to do. So, and I look forward to our next conversation.
Well, thank you so much. It's really been my pleasure.